the first cases we have done. When I say we, it's me and Dr. Devesh Dholakia. We started doing our high grades together. This is about 8 or 9 years old. This is the reduction we got, and that's the fusion mass seen at the end of 1 year. So you can do this without navigation, as you can see here, using landmarks like we used yesterday for the S1 screw, using the tube. Or you can use 2D navigation, or you can use 3D navigation. The crux is it has to be, this is what you need to get in for the S1, is a tricortical hold. Unless you have good bony purchases, this is not going to work. My philosophy is restoration of the anterior structures rather than relying on the screws to hold it. And it goes with this puka chisels. These are made in India, commercially available. Serial jacking up after a release is what restores the local lordosis and gives you a good result. So the idea is, if this is the listhesis, if this was L5 and that's S1 and that's the listhesis you're having, you have to serially jack it up. Use the annulus and the ligaments anteriorly and posteriorly, like you would do a ligamentotrexis or a distal and radius. That's the one you need to have. So the soft tissues, once their height is restored, will not expand beyond a certain point, and they will pull the bone back into its place. And then when it is restored, you put in an adequate size cage. This cage then becomes a weight-bearing construct, taking away the stress from the screws and giving you a much higher chance of fusing this segment. So this is a case that we did. I'm just going to play this video through. So we use a Jackson table to position. It's much easier to give positions here. For L5S1, the patient has to be in head high so that the disc space is straight and you can work straight up. So that's how you go. I'm going to skip through certain parts of the video to the main procedure. So a facetectomy has been done. I use a chisel. We have you have to see the tip of the superior facet of S1 and then take it out so that you have your working space. That's a cambium triangle. You can use a nibbler or a chisel again. In this case, we used the nibbler because the bone quality wasn't very optimal. Once this area is cleared, it was a very narrow, stiff, a decompression is done. That's the dual. You have to be very careful doing this because there will be a lot of adhesions here and a mesh of epidural. So take your time. Having a dural leak here is not going to be making it easy. You can manage it definitely, but it unnecessarily increases your headache. So once this is done, so that's the disc space. Barely taking in number 4 Penfield. This is a 2.5 millimeter thick, 6 millimeter wide puka, not getting in. So then using a 2 millimeter Kerrison rounger, just nibbling the posterior superior edge using a 3-0 lumbar curate to make that initial entry. You have to be very patient here, not try to be fast and impatient. That's what will get you beyond the cartilaginous end plate into the bony end plate, and that's when the disasters happen. Once you have adequate space, you just try and see the direction in which the disc space is and put in your blunt pukas in that direction. Once you have once you have done that, you have to just, this is the puka in, gradually jack it up. It's like pulling up a car after it's got a puncture. You have to gradually do it. Once you've made space, you again use your curates to prepare the bony end plates. Unless your bony end plates are well prepped, it will not be a successful surgery. And then you gradually, you can see here, this is what I'm doing outside, but this is what's happening inside. You gradually open up, let the puka be in place for a couple of seconds, maybe half a minute to a minute, so that the soft tissue structures get time to stretch. And as they stretch, they pull in the segment that has fallen ahead. You have to serially go in. This is the most important part of the surgery. If you do this patiently, you will get, as you can see now, this is a 12 millimeter nerve root retractor. And slowly now, it's getting, initially when we started, this was barely going in, but as you start jacking it up, it slowly becomes more and more loose inside. That's a sign that you're getting some restoration there. So that's the gradual jacking up. And so once, this is the final puka that we used in this case. This is, I think, a 12 millimeter. So once this is done, leave it for some time, let it stretch out, This is optimal tension. At this stage, at least in the initial cases, you should be taking a lateral to check how much reduction you've had and whether the disc height restoration is good enough. Once this is done, then go to the opposite side, use the additional space you've got to curate the opposite end plates and make an adequate fusion mass. And once that is done, bone graft using a funnel, and that's the trial going in. Check with the trial that it's seated adequately and the reduction is good. You'll have some bleed at this stage. Pack it up because the epidurals are now, which were lying dormant, have opened up after a lot of time. And that's the cage going in. I use a bullet, soft and pointed nose cage so that as it goes in, it distracts the disc space. That's the cage going in. Check for all the nerve roots are adequately decompressed, and that's it. And that's the over-the-top decompression. You will have to do it in all your high-grade listhesis to see that the opposite side root is free. Otherwise, the osteophytic facet joint on the opposite side is going to pinch on your exiting root and give you grief later. Once this is, I can actually move my ballpoint on that side. That's the level of decompression you should expect. It's a little easier once you have done the cage distraction. We use an O-arm to put our screws. So all the screws using the navigation, you just put it in. The idea is to go as wide as possible so that you get a long medialized and the thickest possible screw to put inside. And preferably use reduction screws. So reduction screws would kind of help you with the last one grade of reduction that goes in. So you actually start very, very wide. So I'm actually going about 6-7 centimeters wide to the midline. And then you get a nice screw that is here rather than a screw that is straight. So that gives you a good purchase. So once your tapping is done, the screws are in, the navigation allows you to see where your screws are going in. This especially is helpful when you're putting the screw in a small L5 dysplastic kind of posterior element case where the pedicle is going to be very small. Once all your screws are in, put in a Lordos rod inside. Tighten the lower one first and then tighten the upper one so that gets the last bit of reduction done. And I think that's, I'll just skip to the last part. There must be, okay, there will be an X-ray later. So that's the reduction we have got, which is fairly good. This is not a grade 0 reduction. We've got it to grade 1. But what's good is the restoration of the height. So the foramen is now this high. So that's the reason you don't end up with root palsy, because you have actually restored the reduction back. It can be done in multiple level cases like this where the restoration is good. You've restored most of the parameters. And like this syndromic, this lady is now 6 years post-op with a solid fusion, and this is the level of stability at 1 month. You can make them squat and sit down because it is inherently a very stable construct. We have published these cases. These are some of the unions we have seen. We have a total high-grade follow-up of more than 100 cases now, and we have published 52 in the, with 2-year follow-up and presented it at various conferences. So it's a good procedure to have in your armamentarium. It's very, yesterday if you saw, the blood loss was not even crossing about 50 or 60 cc, and recovery is fast. The soft tissues help you in the stability. Of course, there's a long operative time and long learning curve, but there is a long learning curve for all spine surgeries. Thank you.